Thank you for the opportunity for being here and speaking to you about a topic of where the cancer centers of the future should look like. And I'm going to have a few slides at the end of this. I thought I would start off with a vision, with a talk, which will mostly be about the implications of targeted therapies. And I'll tell you why this is important, because I think this is obviously it's the biggest cost in cancer care right now is actually targeted therapies. It's not going to go away. There are 1,000 different compounds I'll come back in development, and there are many more coming. And how we're going to address this is not just an issue of cost and so on, and policies and regulatory affairs. It's also how cancer research is conducted, clinical cancer research. I gave this talk last week to a meeting organized by NCI and NIH by Harold Varmus and others, just to try to think how we're going to think about this problem in a global fashion. So here we are. Here we go. So promises of personalized medicine. I'm going to come back to that at the end. So genetic information can be used to predict risk, optimize screening programs, identify disease at earlier stages. Diagnosis will be more precise, and that's a big part of targeted therapies. I'll come back. Provide more accurate information, allow optimization of treatment interventions. And new therapies will be developed that target specific alterations in disease processes and reducing the need for treatments that give high side effects. And I think we all know that there's a few successes already in personalized medicine and cancer, and I'm going to come with a list of them in a minute. The OICR is actually an institute that actually was created for translation research in cancer, actually to go from bedside to products and back into labs and back to the patient. But really, it's about taking discovery that is already there in either here in London, Ontario, or anywhere else in the world, and try how to bring it to patients. And most of it is large team building, and I'll come back to try to address the issues of health innovation and figuring out whether these innovation matters to patients, what's clinically relevant. We have 6 big programs called the innovation programs, which actually most of our activities are around there. Aaron and Finster and Martin Yaffe lead the Millimeter Cancer Challenge imaging pipeline, but in this program there's 250 PhD scientists and MDs which are involved in trying to see smaller tumors, but also be able to say whether they're more aggressive or not. So we have programs in prostate cancer and breast cancer which are about distinguishing early on whether the tumor has a more aggressive potential or not. And that needed not just being strong in imaging and seeing small tumors, but it needs cancer biology, it needs radiochemistry, it needs imaging devices, it needs clinical oncologists, which have been very involved in not only articulating what the research questions and programs would be, but actually how we're going to be evaluating those devices in the future in clinical trials. Today, a lot of my talks will be around genomics, and it's probably because I've been involved in the Human Genome Project and other big projects for 20 years. I'm very comfortable to explain what the challenges there are. And in terms of cancer, we've known for a long time that there are genomic abnormalities. When you look under the microscope, most cells have abnormal karyotypes. So this one you can see multiple chromosome 2s and so on. But since we've been sequencing entire genomes, we see typically about 10,000 mutations in the cancer cell which are not a normal genome. We have a few AMLs which only have 1,000 mutations. We've actually had some breast cancer cells which have over 10 million mutations, somatic mutations. So there's a wide range in the number of variation, but generally it's quite large. Most of those mutations are due to a at one point, DNA instability in the cancer causes accumulation of mutation during mitosis of cancer cells. But some of those mutations actually give a growth advantage. We can suspect that there's not just one Herceptin positive or whatever, but there could be 50 to 100 drivers. Mutations actually confer a growth advantage in any cancer cell. And so those of them these are the ones we'd like to be able to identify. So these are examples of genomic abnormalities, which are really examples of matched to drugs, so the targeted therapies, and also true examples of personalized medicine, because we're using genomic information to actually select the treatment for patients. So BCR-ABL, of course, with Glivec, BRCA1, BRCA2, germline mutations, and PARP inhibitors, EGFR, and so on. So there are many Since the year 2000, almost every year we have a major story that comes out. Last year, of course, was BRAF, or 2 years ago, BRAF inhibitors and melanoma. There are actually, for each of these, there's generally about 10 companies working on each of them, and the number of products in development is about 1,000 in drug industry right at this point, so for about 50 targets, 50 to 100 targets. So there's a lot more targeted therapies coming. And there will be more because our knowledge of cancer genomes continues to grow, particularly because of technology. So at the height of the Genome project at MIT, so I started here to be involved with all these technologies, but it needed 200 people and 200 machines, about 15 months to sequence the genome. We're now sequencing a cancer genome normal on an instrument in a week, the high-sec instruments. And we actually even have technology, I'll speak later, which have a potential to sequence a genome in about 15 minutes in a few years. And we're using little parts of those technologies that are working to sequence actual genes in patients with metastatic disease to select them to patient clinical trials. So rapid evolution of the technology is allowing very intense studies of cancer genomes. So at this point, we actually have 19,000 cancer genomes which are started. The studies have started through large collaborations. Each of these bullet points here represent 500 tumors to be sequenced, an alliance of pathologists, clinicians, and genome centers. And at this point, we have 40 tumor types across the world which are being studied. And there's still a lot of rare tumors which are missing pediatric tumors. But the fact is that the targeted therapies that we're seeing in development today reflect a very limited knowledge of the cancer genome 5 years ago. The targeted therapies in development in the next 10 years will actually reflect a lot more studies of cancer genomes and so on. So head and neck, I know we have a speaker today, has a lot of notch mutations, so it's about time to start looking at notch mutations as potential therapies for subsets of patients with head and neck. And this is information that's about a month old. Now, what we've done with the omics technologies is actually become quite good at finding new biomarkers, things which are different in cancer cells than normal cells. And we have potential ideas on how to bring them as markers to predict risk, markers for early detection, biomarkers to actually tell something about prognosis or drug response, and developing new therapies. The big rate-limiting step in personalized medicine is actually the fact that these things need to be validated in a clinical setting. So if you want to be able to study, show that something modifies risk or can be used early detection, you need a population-based study. If you want to be able to show that a new biomarker is important in predictive drug response or give a new drug, you need clinical trials. This is pretty much what has not been happening in a matched way. As we've been evolving the technologies, this gets getting bigger and bigger in terms of number of potential, but we have not created the infrastructure to actually validate all this new information that's coming forward, either in populations or in clinical trials. And that's really key, and I think a key message for this team today, that if you want to become a leader in targeted therapies or in almost anything that involves the evaluation of biomarkers, imaging probes, or risk, you need to be very good in clinical research. OICR has actually been involved in using genomics at all stages of clinical development, and I'm not going to go through all these different things. Actually, we lead the secretariat for this large consortium I mentioned a few minutes ago, but we use genomics at many different stages. Today, I thought I would talk about clinical trials because I think it's very relevant for this audience. So OICR helped support clinical trial sites in the province, including in London, through the creation of infrastructure, databases, the establishment of OCREB, the Province-Wide Ethics Board, for multi-center trials, and that actually initially doubled the number of patients in clinical trials, then it stabilized about 50% increase over the benchmark. But those were the early days of the OCRN, is to try to augment the number of patients in trials. What we're trying to do now is actually make the trials more informative. Who is a responder, or which drug works, and how fast can you get that information so you can stop ineffective therapies and actually put more patients on the right therapies. And so the types of projects which Janet Dancey and others and groups involved in this group involved actually using much more genomics, imaging, cancer stem cells, and other tools to actually be able to inform the clinical trial response, why a trial didn't work or again, speed at which people respond. So the use of imaging in trials are examples. here. This one is a study of cancer stem cells in clinical trials. And I thought I would just spend time on genomics cohort study for Ontario cancer trials, which is really an example of how to learn to use targeted therapies. So I'm going to change my language. I didn't go through all the different ways we're calling mutations at the basic research labs, but for the group, the audience today, I think we need to be just keeping in mind that there's a group of mutations which are called actionable. And these are genetic abnormalities which have the potential to impact treatment recommendations for predictive or prognostic reasons, and they have, again, implications for prognosis and treatment response. So there are actually most of these mutations I mentioned before. My point of re-showing this slide again is this slide plus the next one tells you you have to think it differently than what you actually may have been learning from the pharma companies and the way the history of most of these drugs. The fact we always think of BRAF as being a melanoma mutation, but I'm going to show you, you can see BRAF in multiple types of cancers, EGFR, KIT, and so on. Most of those mutations, although they were studied in one tumor type, shown to be a driver, and shown to have a drug in one tumor type, most of those mutations are found in multiple types of cancers. For example, so here I'm basically showing you most of the mutations before. Many of these are called actionable mutations, with BRAF, for example, being here. Very high in melanoma. These are the 10 most type of common cancer for 10 types of cancers. And you can see melanoma, BRAF mutation is often seen in melanoma. And of course, there's an indication for BRAF inhibitors to these patients. But you can see BRAF mutations are found in multiple types of cancers. You can see KRAS, NRAS, PIK3CA mutations seen in almost every cancer and so on. If those mutations were drivers in melanoma, they likely were drivers in the development of most of those cancers because they're all over the background mutation rate. It is possible that a BRAF mutation in HCC will actually have, those patients would respond to BRAF inhibitors. So there's actually very few mutations which are cancer type specific. Most of them are actually seen at different frequencies in almost every type of cancer. If that's true, we may actually have therapies that exist already for which some patients would respond, but we are not testing them. So that's the hypothesis of this next study, are there more drugs available right now to patients which are not being tested in other tumor types? So people started looking at that first through, in terms of technology using genotyping. So many of these genes have a recurrent mutation. A mutation that, when it occurs, is often that same base change which happens. For example, BRAF has a significant one, but most of those genes have other mutations that occur in different patients, and they're not being looked at by these genotyping technologies. If you want to be able to study these genes, you need to sequence. And if you need to sequence, you have to then go back to those big slide of all these technologies we have. Which ones or any of them actually usable in a clinical setting to sequence large number of genes. So this would be a major step for a clinical diagnostic lab to do the level of sequencing we're going to be talking about. Which ones would work? Can they work on pathology samples, the FFPE samples, or we need fresh biopsies? What's the turnaround time? Sequencing a whole genome. Maybe I mentioned it took a week to sequence a whole genome. It takes us months to analyze it. And a patient which needs a clinical decision can't wait months. So we need to have a fast turnaround. How do we decode this complex information? How do we report back to the physician, from all these tens of thousands of somatic mutations, this is the one that matters to your patient, which you should consider your treatment intervention, and so on. So these are all the types of, there's more questions on how to do it. And finally, I think for clinical research setting is how would we use a clinical trial research environment to actually show proof of concept for all these multiple hypotheses which can come when you have multiple drugs and multiple mutations and multiple tumor types. So we decided a pilot study to answer some of these questions. There's a group in London led by Eric, which is part of the study. But it was initiated by Linian Su and Janet Dancey to look at patients with metastatic disease, patients which are beyond standard of care, or they've received all the therapies that they should have, yet they still have cancer. And what we are obtaining right now is a fresh biopsy, sequencing all the actionable genes that we know of for which there is a drug, and providing that report back to the clinical group, which then makes a decision whether they're going to move patients to a trial that would match that information. So our current study, pilot study, is about 50, 80 patients this year. We're on track to doing it, and we should be able to get a start with 1,000 patient studies next year. It's a study that needs a clinical center that's really well organized. It's not about the genomics. It's really about a clinical group team which asks for a biopsy imaging lab able to give a biopsy that goes to pathology lab, quality diagnosis is done, quality DNA is done, ability to send that to a genomics lab, which could be in your CLIA lab, but use that next generation technology, find something new, validate it using another technology if necessary, which is CLIA certified, and give it back a report. So all these different components are really critical. Without this, the study is not possible. There are many what we call third generation technologies, which are even faster than the ones I was discussing earlier, but actually they don't actually do whole genomes at this point. But we use one called PacBauer system, which actually for every exon we want to sequence, we make a small PCR product. We make it circular, and our sequence lengths are about 10,000 bases. So actually we sequence around a DNA molecule. We sequence one DNA molecule at a time, multiple times, which gives us a lot of redundancy in that sequence. We use a technology, the well size is 1 zeptoliter big, that's 10 to minus 21, has one DNA molecule, one DNA polymerase, floating nucleotides, and we can read off the sequence every 200 milliseconds when a new base gets added. So within 15 minutes, we have this information. Using two different technologies to be able to look at those mutations. So we started with a set of tumors for which we knew the mutation from a pathology lab, most of them at PMH. And we looked at both this PacBauer technology for series sequencing and a genotyping technology, which has been published by other groups. Both technologies worked really well, so I'm going to skip over this. But it's critical that the genotyping technology finds recurrent mutations, sequencing finds other mutations in the genes, so you're actually sequencing the entire gene, so you're actually finding more information. Both technologies work well on paraffin tissue, which is really important for the pathologists. This is to show we find new tumor mutations. But beyond this, the study needs to create a database to collect information. We need to generate a report to the physician for each mutation. We need to say this mutation has been seen before and what type of cancer, whether a matched drug exists for it, and in what clinical trial it has been looked at. And very often it's not in the tumor type for which the patient exists. We generate a report which goes back in the patient file. Although it's called a research information, it's not a clinical information, but this is a report for which the clinical trialists use to make decisions on moving patients to trials. So this study is not up to date, but I could talk a lot about this. It's over about 35 patients at this point, but you can see a few things. Patients came here, metastatic disease of any type. We have a bit more colon and breast, but we have, so from London here, I see we had ovarian cancer patient, and we had poorly differentiated parotid cancer patient, again, beyond standard of care. Biopsies were obtained, number of cores. We have a deadline of 3 weeks between seeing a patient and giving the report back to the clinical group. And so that involves all the different steps I just mentioned, including an expert panel review from all different groups to make decisions. So mutations were found in 60% of patients. So 60% of patients which were beyond standard of care, now you can identify mutation for which a drug exists in clinical development. And of those 60%, half of them actually went on to a trial which was matched. This is, again, just a proof of principle study, and I'm not even sure why they didn't all go. I know the first patient, we didn't meet our 3-week deadline, and the patient went on to another drug. But we're getting faster at doing these decisions, and it's getting more and more having an impact on the trial. So the patient here, for example, again, mutations, KRAS are not surprising, but AKT mutation in breast cancer, PDGFR patient in this patient with parotid cancer, and some of them, of course, were impacted by the trial they went on. So in terms of benchmark, we're able, the participation rate in this trial is 100%. We're able to get biopsy in 95% of cases, and then if so, we're able to get a quality sample. I'm going to come back to some of the, if I have time, on the fact that the CLIA lab, the pathology labs, don't always know how to work with small samples. The technologies can, but these technologies have been not CLIA certified. And a few others. I'm going to just join. So this became multi-center trials, and I think here we needed multiple disciplines coming together, oncologists, pathologists, informatics, and so on, to actually make a decision before we give a report. A big issue with this type of trial and any type of trial that wants to do personalized medicine is that you're always looking at a snapshot of a tumor. I have a tumor mass. So of course the tumor may have evolved with having multiple mutations. These little D's here represent those driver mutations, but as they disseminate, we actually have a heterogeneity in the types of mutations you'll find in different masses. And after therapies, which represent actually most of the patients in this study, because they've had multiple therapies, you again have emergent resistant clones. So cancer does evolve over time, and if you actually would want to always be picking the best mutation, you want to have serial biopsies. And eventually you can think of that this is not a trial, but it's a study of every cancer patient. We're doing a genomic analysis. And it's within this study that you subset people with a certain mutation and you do your drug trials. In a more specific way, we might take, if we were to take 1,000 patients, we know we would see enough PIK3CA mutations, KRAS mutations, and BRAF mutation in these different tumor types to be able to randomize, independent of the tumor type. If you have a mutation, we could give a MEK inhibitor, a BRAF inhibitor, and so on. So we could devise multiple nested trial studies on 3 common mutations for which we don't know, except for our knowledge of BRAF and melanoma. We might discover the importance of BRAF in ovarian cancer or other types of cancer where they're seen. And of course, we find new mutations for this. For example, when Pfizer looked at the AKT mutation in breast, we wouldn't have had enough study to actually do a study on AKT mutation in breast. But if there were multiple centers which actually had access to this patient, crizotinib might do, or some of this, no, this is not good, but anyway, there are companies very interested in patients which have been characterized for these mutations in other tumor types, and that could show other indications for tumors. So translation research models need change, and this a bit what the funding agencies are thinking right now. Are we going to continue with status quo, which every group is going to do his own hypothesis in unselected patients? We're going to give a drug to 100 patients with breast cancer, or are we going to start narrowing down to 100 cases of breast cancer with the mutation which makes sense mechanistically to which to give the drug? So I think that is starting to change. And also, are we going to only start sharing information on successful trials years later? I think that is going to, there's a request. If you can read Nature and so on, you'll realize people think this has to change. More and more, we're going to be working with large cohorts, well-characterized patients, and often using the selection that comes from genomics or other omics to actually decide which patients goes on which trials. We're going to be using more and more of these biomarkers, circulating tumor cells imaging, to monitor response so we can know faster. And then finally, because this now becomes a power issue, you're not going to get enough BRAF mutations in ovarian cancer in London or in Toronto or anywhere. There needs to be some coordination on sharing information, such as at least information of mutation, tumor type, and eventually outcomes, so we can start being able to learn more about how these targeted therapies do in rare subsets. Ultimately, cancer diagnosis was always about the patient and the doctor, and there's a lot of information that's being collected. More and more, we're using a lot more of these different technologies to collect the information and report back to the physician and clinician, and we're dealing a lot with the issues how to report back something that's complex and big into something that's clinically useful. So that new framework is needed to be considered, and I don't think I have the answer on the framework, and I don't think anyone has at PMH or Memorial Sloan Kettering. I think we need to innovate on the model, and again, cancer centers might want to address different parts of of these challenges and framework to actually see that what parts work better. So last slide, did this on the train, Glenn, for you, so you should be watching. Kidding. So these were ideas, establish effective interactions between clinical trials, units, pathology, imaging. I think that was really critical for the study I was just mentioning, and I think this has to happen in any immune cancer center. Adopt consent mechanisms that allow for longitudinal data collection and data sharing. So there are new norms in consent which have been used, are used more and more in genomics and so on. They also need to be applied, and they're used in ICGC, but they have to be applied in a clinical trial setting to be able to learn from this information across studies. You have to invest in pathology and informatics infrastructure that's going to support clinical research. Follows up to this. I'd say you want to monitor new technologies, being that the ones that can be adapted to the diagnostic labs. I can tell you it's very expensive, very costly at this point. These technologies often cost $500,000 and they change every 6 months. So you have to make a decision when you want to jump in. I don't think you want to be the last one to jump in your clinic, your genetic testing lab to be the last one to do it. So the question of you want to be an early adopter, but you also have to be careful not to investing a bit too early. But I think this is certainly something to think about. We're not going to do clinical management in genome with a genome center next door like we have at PMH for a long time. This type of data generation of clinical samples has to be moved to the CLIA lab. And I would say foster multidisciplinary training for all. I meant not just to the students, but all staff, all disciplines. And I think it's important to think about your national and international networking. I should actually thank Lillian Sue and Janet Dancey and others, Eric Winquist and others for this project. Thank you.